Yes, sir, we are good.
Okay. Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present webinar on the occasion of World Population Day, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of managing dyslipidemia and provide healthy life to growing young population in India. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of patients affected with dyslipidemia. Our distinguished speaker, esteemed moderator, and expert panelists are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our speaker, Dr. Prashant Advani, sir, moderator, Dr. Vidyut Jain, sir, and panelist, Dr. Neeraj Prasad, sir, who have generously decided to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed faculty for this program. Let me have honor to welcome esteemed moderator for today, Dr. Vidyut Jain, sir. Sir is consultant cardiologist at Choitram Hospital and CHL Hospital, Indore. Sir was national president of CSI between 2008 to 2012. Sir is faculty in ACC, TCT CAP, ISCUS, CSI, and IAE. Sir was national convener of Hypertension Sub-Council of CSI between 2016 to 2018. Sir is EC member and joint secretary at Indian Academy of Echocardiography in 2008 to 2010. Sir was also scientific council member for Asia Pacific Society of Cardiology between 2006 to 2012. Sir is editorial board member of Asia Pacific Journal of Cardiology, Indian Heart Journal, and Journal of Echocardiography. Sir is abstract reviewer for European Society of Cardiology conferences in 2017 to 2023. Sir is principal investigator in 17 international phase 2 and phase 3 trials. Sir has 38 publications and chapters in books to his credit. A warm welcome to you, sir. Let me have privilege to welcome the expert panelist for today, Dr. Neeraj Prasad, sir. Sir is Associate Director of Cardiology in Medanta, Ranchi. Sir specializes in procedures such as coronary intervention, primary PTCA, valvular heart discharge intervention procedure, congenital heart disease intervention, pacemaker implantation, ICD, and CRTD. Sir was recipient of Young Cardiology ISC Award in 2000. Sir received a Pioneer in Interventional Cardiology Jharkhand Award. Sir has many published articles in various reputed journals. Thank you, sir, for joining today's program. Let me have honor to introduce the expert speaker for today, Dr. Prashant Advani, sir. Sir is Senior Consultant, Clinical and Preventive Cardiologist at Advani Heartline and Metabolic Center, Raipur. Sir is Director of Advani Heartline and Metabolic Center, Raipur. Sir is Honorary and Visiting Consultant at various corporate hospitals at Raipur. Sir is speaker at various national and international cardiac and cardiometabolic events and congresses. Sir has published many research articles at various national and international index journals. Sir is passionate about disseminating current medical knowledge amongst the medical professional through seminars, CMEs, ad boards, and webinars and conferences. So finally, thank you, sir, for joining. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all about the agenda for today's meeting. We'll kickstart the program with the opening remarks and context setting from our respected moderator, Dr. Vidyut Jain, sir. The meeting will proceed further with the session on abnormal lipids in young Indians by Dr. Prashant Advani, sir. Following this, we'll have quick comments from the moderator on the session, and this will be followed by a panel discussion. I request audience to post their questions in the comment box so that we can take up those questions at the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of abnormal lipids in young Indians. I request our moderator, Dr. Vidyut Jain, sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you very much. Let me try to see if I can share my slide.
Yes.
Otherwise, you will need to share. Okay.
Okay.
I don't know. Can you see?
Yes, sir. It's visible.
Can you
Yes,
see
sir,
some
we can see.
slides?
Yes, sir. Yes, sir.
Is
It's
it
visible.
moving?
Yes, sir.
Moving?
Yes, sir. We need to make it full screen.
Okay. So, dear friends, today we
So,
are going
full
to have a very important talk, particularly on the day of the World Population Day. We know World Population Day is very, very important because population makes society for us, and society should remain healthy. That is what is our aim. So how to keep ourselves healthy from non-communicable diseases? So one of the important diseases is coronary artery disease, which is unfortunately related to dyslipidemia in most of the cases. So dyslipidemia always is a challenge in the management of the coronary artery disease because we have to have primary prevention, but very, very importantly, secondary prevention too. Today's topic is particularly young Indian and dyslipidemia. So I'll just give 2 slides or 3 slides more and try to tackle. So what is the prevalence in dyslipidemia in India? We'll know various states have a different type of the people living in our country and different food habits, but also different genetic background also. So we know dyslipidemia is definitely very common in India, and around we have a large population up to 185 million patients who have got very high LDL cholesterol. So this remains always important, LDL. So LDL definitely an oxidized LDL, that is very, very important as far as the atherosclerotic obstruction in coronary artery disease is concerned. So well,
so we can make it full screen.
is it,
Are
are you able to see?
you able to see full screen?
In case otherwise you share it.
Okay.
Yeah,
Sir.
sir, it's
Okay,
not full screen and neither it is changing.
Is
Okay,
it
okay,
changing or not?
Nirav,
No.
make it Nirav, make it make me host or give me permission.
So I am stopping, you can share.
my
Yes,
screen.
sir, you can share the screen.
Okay.
You have my slides, okay?
Yes, sir.
Okay, please.
I'll display.
The one which is latest.
Yes, sir. Are you able to see the
Next
screen?
slide, please.
Full screen?
Yeah, next one.
Yes.
Next. So we all know the prevalence of the dyslipidemia is very common in India. Around 185 million people have high LDL cholesterol. And high LDL cholesterol as well as the oxidized LDL. These are the mainly concern for us because they are inducing the atherosclerotic plaque obstruction in the coronary artery or any vascular tree. In addition, we have got low HDL and high triglyceride levels, which are very uniformly prevalent all across India. So these are the 2 or 3 important aspects of the dyslipidemia, which is going to be discussed. Next slide, please. So how long this dyslipidemia has been going on as per the management of the coronary artery disease. Next slide, please. And next. And next. Yeah. So just imagine one of the report which I am trying to show here. This patient total cholesterol is 750, triglyceride is 90, and LDL is 711. This is the actual report of patient, a young patient. He is hardly 22 years. This report is up to 4-5 years old, but I am showing it directly because it reflects such dyslipidemia is also known to occur in our country also. This is known as homozygous hypercholesterolemia, which is very difficult to treat, very diagnosed early in the infancy, and patient may have a very bad outcome by the age of 20 and 30. So next slide, please. So when this dyslipidemia or cholesterol business started, next slide, please. So dyslipidemia or cholesterol is not today's story. This story has been documented approximately of 3,500 years before also, because when the CT scan of mummies of the certain dead bodies were done, it had been found that there was an atherosclerotic cholesterol deposit in the muscular tree. So the story is not new. The story is very old. We are trying to unfold as much as possible and trying to understand that this is an important aspect. Next slide, please. Next slide, please. Next. So rationale for pushing LDL cholesterol, why we should go as much as lower? Because if you go lower, you will possibly reduce the incidence of the coronary artery disease. And we know if your LDL is below 50, your incidence is around 4.4. But if it is around 190, it may go up to 34%, 34.4% coronary event. Next slide, please. So why Indians have such issue? Next slide, please. So we know we have a different genetic and lifestyle factor which are very important in increased prevalence of coronary artery disease. An estimated prevalence of 15% of Indian youngsters are having dyslipidemia as compared to 5 to 10% which has been the rest of the world. So studies are also reported. ApoB is significantly high in Asian Indian as compared to American. So let's see what is more important. Next slide, please. The most important, particularly in the younger individual, is dyslipidemia due to some genetic factors. Can I have next slide, please? So we know ApoB gene polymorphism can lead to hyperlipidemia, and particularly it has been reported in migrant Indians who are living in the US. Similarly, ApoE3 and ApoE3 phenotype is known to be associated with low level of HDL-C. In ApoC3, SST gene polymorphism is associated with a very high plasma triglyceride level. So this is in short, I tried to highlight, well, atherosclerosis is a very old disease. Cholesterol has been implicated in its causation. We have a young Indian who are suffering from it. And now we have to look beyond the routine genetic routine factor. We should understand and try to analyze whether there are genetic factors which are making us more vulnerable to have dyslipidemia, particularly in a young individual. So now I hand over the talk to the Dr. Advani, who is going to discuss about what is the prevalence, what is the incidence, what is the cause for particularly hyperlipidemia in young Indian. So Dr. Advani, please go ahead.
Thanks, Chancellor Emcure for the event. Of course, he set the ball rolling, and most of the things the context has been set. I'll rush through. We are past the designated time. I start sharing screen. Please help me stay around in case it glitch. Can you see my screen?
So please make it a full screen.
Yeah, full screen. I'm looking for it here. No. Yeah. So as Dr. Vidhu Jain sir has said that dyslipidemia is a very important consideration in youngsters. So youngster means the ones who have just become adult at 18, 19, and this is happening. Today afternoon, I saw a patient, and he's 23, everything was normal. Angiogram was now, there's a big shot here as a son of an industrialist, Agrawal family, and I had a florid anterior wall MI. And this guy, so everything was the routine lab reports. So what did he ignore? Was LDL was hovering around 132 and the range was written below 140 normal. So our lab report and our scrupulous. So we are sitting on a ticking atom bomb of metabolic syndrome, and one of the very important manifestation is dyslipidemia. Since we are focusing on this facet of this metabolic syndrome, so I'll hover on this because we are witnessing so much of premature life losses. So my presentation will flow through the same flow chart, the pathophysiology, the incidence prevalence, Dr. Jain sir has already covered. And I'll show some nuances and nitty-gritties on how to manage it. It's very simple. I think in hypertension, diabetes, we have to first like target organ damage and organ, to streamline comorbidity assessment, and then do a phenotyping and then choose the drug. But in dyslipidemia, you have targets and you have very simple flow chart of drugs. Youngsters are at peril because we have, as I said, the genetics load the guns and kind of lifestyle that we have in India. Beginning from us, we all share some kind of, so a good paper, I'm fellow American, cardiovascular kidney metabolic syndrome. We all are kind of sitting in this elite panel also in some stage 1 or stage 2 of cardiovascular kidney metabolic is some amount of UDA, so visceral fat, perinephric fat, and this contributes to hepatic fat contributes to the overall homeostasis, a very negative inflammatory marker, free fatty acids, so much of cytokines and insulin resistance. And this is where all this emanates a very monstrous, humongous dyslipidemia And they said that in USA, 25% people are suffering. In India, close to 5 crore in high LDL. But whatever you report, it's underreporting, because nobody can fathom in such a hugely populous country. And diabetes, pre-diabetes incidence is growing. They say that 10 crore diabetes, I say much beyond, and pre-diabetes must be 20, 30, or 40 crore. Nobody can say the incidence because of the way. And this all this is going in monstrous proportion. And as they say, 50 lakh people die of NCDs. It's more than that in India. And premature heart disease, premature life. Now, we know that we have been knowing that the course of atherosclerosis in India is very malignant. Manifestations are very dreaded, unheralded. And all these things put together, I think ischemic heart disease taking its toll from 2009 to 2019 has gone by leap and bounds. This is not a good news. In spite of so many awareness programs and so much of industry awareness, population level, world population being world population day to day, but the percolation down to the needy patient is still abysmally low. And all this is accelerated atherosclerosis coming from insulin resistance. Even in pre-diabetic state, we always know that the stage is all set for macrovascular complication. So what I'm aiming is my major adverse cardiovascular and cerebrovascular events and nascent atherosclerosis in peripheral vessel, which we don't see. So what we aim for primary prevention in India is actually it already hidden high risk. Secondary prevention, and we have widespread inflammation, vascular inflammation, which could be at the frontier of the target in future, and a vessel's on fire, and you have a subintimal plaque that ruptures, and there's a thrombus formation and ischemically non-preconditioned myocardium, all of the sudden, which I witnessed today morning. And I keep, you and me always see this type of phenotype in India. And premature heart attack is talk of the day, and people in late 20s and 30s are dying. And dyslipidemia is contributing other in conjunction with other risk factor immensely. So if we tackle dyslipidemia in young heart attack or young stroke, we can prevent all these things. So dyslipidemia doesn't come alone. You have always diabolically accomplices, dysglycemia, diabetes, pre-diabetes, or hypertension, and other metabolic and structural comorbidities. And then we have to see risk. Everything in chronic NCD management is risk management. So if I'm managing dyslipidemia, I'm also assessing the entire cardiovascular risk. And then if I control is LDL to a designated target, we know that LAI is this document and CSI is recent guideline. You have to go down, taking a departure from the Western targets. And then you have to see the residual risk and thrombotic risk, inflammatory risk. Everything is risk assessment. And we know that LDL is this half story done. I'll come back to it. You have other lipoprotein literates that Dr. Vidhu sir also said. Then there are so many remnant particles. The West discards triglyceride as a risk factor, but in India, we know that these remnant particles also can travel through or by transcytosis or percolate through the endothelium. So they make the plaque more inflamed. And incidence of familial, Dr. Vidhu has also said, familial hypercholesterol, we don't look for it, but it doesn't exist. So around close to 60 to 70 lakh people in India suffer from this. They themselves are not in the want of awareness and cascading screening. And young Indians are at peril. And the common abnormalities in medical school learning, and not so high LDL, but very qualitatively abnormal, small, dense, oxidized. Even LDL are rich in triglyceride, and they travel through, and they are hydrolyzed in intra the substance, the parenchyma of the vessel wall, and through monoacyl glycerol, which is very inflammatory, and that makes the flour very vulnerable, and thick cap becomes thin cap. The LDL is also rich in triglyceride. Then you have remnant particles of various sizes with record. So you have LDL. Not so high LDL, of course, then high triglyceride, low HDL, because if you have lipoprotein lipase is insulin resistant in a state, lipoprotein lipase is resisting, is not being controlled by the insulin, so that you have a particle generation rich in triglyceride, and the remnants have also LDL left out. And you chymomyocoraptant or intermediate density, all this is basic medical school and learning. So how to screen that the incident is so many, your population is at larger at risk, how to go about it. So it is a very tough task. Again, I'm coming back to the pathophysiology, which here it seems very complex, but then it's a basic medical physiology. You have an endogenous cycle, and you have exogenous. You eat something, and your way to the brain and the vessel is through the gut. So what you eat, you have carb-rich diet and calorie-rich, saturated fat-rich diet in India, chylomicrons are generated going straight to the peripheral muscle, which are the biggest buyer, and there's in the state of insulin resistance, lipoprotein lipase is not able to. There are so many remnants rich in LDL still, because otherwise what should have happened? It should all be in LDL and should go down. But then it's the remnant particles. So you have LDL high, but then there's so many remnant still having cholesterol in them. And then there's similarly VLDL coming out of hepatic cycle, and that's where so much of insulin resistant hepatic level. You have fatty liver, you have NASHs and insulin resistant. So much of new glucurogen unheralded. So much of VLDL production again going to the same. And then this is the pathophysiology in Indian setting. A youngster who is just touching the adulthood is witnessing all those things. So you have high LDL would be hovering around 130, 40. But then unlike the case Sarah said around 700, which is homogeneous, or put to 300 in western part, it's not so high here, but then it's very small in because of the insulin resistant inadequate lipohydrolysis balance. And you have CETP not getting, so you have CVD, and that's where you have low HDL there and high ApoB. So these are Indian specific things. Everything is coming from our genetics and the kind of phenotype that we epigenetics, the expressions, the visceral adiposity. Instead of knowing this thing, very difficult and to explain people and choose the therapies in order to make the patient have his risk coming down to ground zero. It's very difficult. So age-related change, and if we age, we raise our LDL, we derange our biochemical. LDL is not a biomarker. LDL is a causative agent. Of course, it's a biomarker, but it's a causative agent, and there's a direct a cause and effect relationship that we, for umpteen number of primary and secondary preventive strategies has demonstrated. Framingham study we always quote, but then it's gone passe. And at age 20, I think there's an 18 or 20 in schools and colleges, and that there have been people who are advocating. I listened to a seminar of Valentin Fuster in the Hispanic people that the school said we have to raise awareness screen. This is a good where you have to again slide here that your risk. This is from LAI, and they keep updating the risk factors and markers. The moment patient walks in my clinic or in all of us clinic, we have to have visually eyeball trained and assess his risk. So these are the major risk factor. Age above 45, 55, I say it has to go down even 5 years more. So age 40 is a risk factor in India. And family history of premature ASCVD is a terrible risk factor. You can't do anything about it. Cigarette smoking, high blood pressure, low HDL-C, these are the risks. And then if you, other features, so many of them, CKD, diabetes, coronary calcium scoring, and other. So this is a complex side. Then how we have to risk assign and then choose the LDL target. Then you, after factoring in these risk factors and markers, you make risk groups. I must tell you, in India, everybody is at high risk. Forget about moderate and low risk in India. High risk, very high risk, and extremely high risk. And LDL contributes to it immensely. So I would say LDL, when I say overall dyslipidemia, India is specific atherogenic dyslipidemia. This is my slide where I say up to 95% of type 2 diabetic patients don't come just with diabetes. They have hidden, overt or covert major adverse cardiovascular risk factor we have to probe. Then these are the external manifestation of dyslipidemia, which we cannot see, right? You have this is, but if you train our eyes, we can, but that this is a medical school thing. This is 3 key points from ESC, which I always show in all of my lipid deliberation, that LDL is a causal of CVD, and it's a wrong exposure, which is somebody's LDL should have been, say, 100 for primary prevention in low risk individual. But he always had 110 right from his age of 90. He lived from 110 LDL till 33, then when he had events. So 13 years, a marginally high LDL has generated a bad lipid legacy for his endothelium. So this is long LDL exposure increases the risk of event. This is very important. And not only that, I am seeing LDL, I am assessing the global risk. That's the crux of story today. And if you have LDL high at younger ages, you're even there. Or somebody who has dyslipidemia later in the age, he had all a perfect, picture perfect LDL in earlier age, and then 60s and 50s, then he raises for various reasons. But the propensity for the one who at a younger age would be higher to have major adverse cardiovascular events. So young versus old, and this is I think in lipidology it doesn't count. You have a risk, you have a designated target. The one with 80 and 90 has the same LDL target, and the one if you have risk at 18 or 22 or 36 or 42 have the same target. MI, sudden cardiac deaths are enormously prevalent. The enormity of the problem is immense, and we have to be very circumspect by these raise awareness in the population. And also the labs, the routine labs that are mushrooming in the corners of cities, and they are not scrupulous in terms of measuring that. You can't have a range. The patient self-assess. 132 people consider as a normal one because the range is written there from 100 to 160. It's gone as an era. It's all risk dependent now. All individuals should have their lipid profile. This is from company, which I agree by age of 18. At the age, the individual understand the significance and measurements, and you have to raise awareness how LDL is important, and frequently and periodically you should. And screening for familial hypercholesterolemia in the ones who have some genetic or a history of premature heart disease. This is an ACC-AHA old one, but this holds true irrespective of you being below 70 and above 75. If you have extremely high risk or high risk, your LDL target should be below 55. In India, we say an extremely high risk 20 or 30 is all fine. And since PCSK9 trials, we know that low LDLs below 20 or in single digit have no any consequence of neurocognitive decline or any other new onset diabetes. Is more of a kind of a concern rather than a hoax or something, and you can't stop even with that concern. So every young adult with evidence of ASCVD should be on a statin, moderate to high dose. Young adult with ASCVD should be treated like any patient, even if he's 18 years old. If the target is not attained or is not tolerated, then you have other incremental high intensity lipid lowering. So I'll come back to this slide where I show ASCVD, you have a high intensity statin to start with. Whatever therapy comes, I was listening to a talk that when inclisiran is hitting the horizon, all this will be passé. No, we are not here to replace statins. Statins are millennium molecules, pleiotropic molecules. They have showed their metal in many of the trials. A statin would always be there unless there is a concern or a statin intolerance. So statins, there could be statin hyporesponders, but statin wouldn't be replaced or substituted. So if you're ASCVD, ACS, stroke, PAD, or CV, you have to have a high intensity. You are not at goal. Say I decided goal of 32. My I decide I write on my prescription LDL goal is 30. Whosoever say whatever, I am going to achieve it. Of course, lifestyle amendments are crux to it, but nobody, irrespective of the exhortation, follow. So there are pill solution for it. Then I do a high intensity stand over and above your bempedoic acid, ezetimibe. And then even after that, you have PCSK9 and now inclisiran. And if you have intolerance, then statin goes away. And then the latter case and the flow rhythm algorithm starts from bempedoic acid, ezetimibe, PCSK9. It's so simple. So lipidology, I'm assigning a target, and then I'm choosing over and above statin incrementally. So total lipid is lipoprotein risk rather than the LDL. I said that LDL related, even if I control LDL, probably I've not mitigated the risk completely. Triglyceride, the remnant particles, the ApoBs and lipoprotein little a's, because they cause instability, endothelial dysfunction, and make the plaque unstable. So this risk is to be dynamically assessed, and they're increased because this is a good slide where I say that are we just treating the tip of iceberg? So much of line underneath. In spite of controlling LDL to the designated stipulated value, residual risk assessment is quintessential part. So I can use for hypertriglyceride over and above in Indian high-risk ASCVD patient for secondary prevention, icosapent which has shown its metal in reducing events, and all other triglyceride-reducing agents have been cosmetic. They have just disease reduction, fenofibrate, cerebritazar in India. So in Indian dyslipidemia, I have to first risk assign and target the LDL to a stipulated period. Use high-dose statin. Use incremental other agents, bempedoic acid and ezetimibe, or PCSK9. PCSK9, to be very practical in Indian setting, is difficult even at our level, emergency level. So the oral drugs are wonderful, and they bring down to stipulated value very nicely if we are astute enough. So key measures to reduce risk of diet and lifestyle, so many things. I can give another sermon for diet and lifestyle. Low carb diet, low in glycemic index, physical activity, muscle building, positive thinking, proper sleep, fruits and vegetable, legume, lentils, and okay, so bring them. You build the muscle. Isometric training, we don't overemphasize about it, but it improves insulin sensitivity, improves lipoprotein lipase activity, all the parameters point, and then shunning tobaccos and alcohols and high the rich carbohydrate sweets and saturated fat containing snacks and beverages is so prevalent that even in spite of having thousands of patients exhorting them again and again, but they don't listen. So again, we have to fall back on the protective the cardiovascular therapies spearheaded by high dose statin. So the era of lipid lowering, high intensity lipid lowering, high intensity statin is part of it. Then I am using incremental lipid lowering drug over and above as an assistant and corollary to statin therapy. So huge pandemic going on. I don't have to prescribe, and statistical jargon is not the message. This statistic may be outdated tomorrow. Our youngsters are at peril, and this syndrome of CKM's cardiovascular kidney metabolic syndrome is prevailing like a monster, and it's in a vicious way. So the age we have to start screening for in Indian and young population, you are young nation, right at 18, the awareness to be generated. And should you find a patient with ASCVD, there are so many no day lapses I don't see under 40 patients who have already had PCI, MI, and they survive, or a story that somebody died of. Under 40, there are 7, 8, 10 patients daily, and I'm sure Dr. Vidhu Jain, even senior and eminent person, must be seeing the same thing. So we have to put them on a high intensity statin and other corollary drugs. So how we are different in India, because our genetics is very heterogeneous. We have widespread cardiovascular inflammation and endothelial dysfunction, subintimal plaques, prone to rupture, thin cap, and full of syndrome, all borderline CVRFs. And they make a kind of this is a good sign. Low grade stenosis, even not visible on invasive angiogram, can give you a florid anterior wall or inferior wall or posterolateral MI with sudden cardiac death. So if you want to de-risk CVD risk, you have to raise awareness about dyslipidemia and bring LDL down to the designated target, which could be 40, 30, 20, or sub 20 with high intensity statin and incremental lipid lowering therapy, and debunk the diabetes, obesity, visceral and ectopic fat, which is the root cause, but it is so difficult to exhort and admonish to the patient. It's very difficult. It's this pandemic of obesity, which is causing all that thing downstream. Anyways, thanks for this, man, and when my next and throwing back into Vidhu sir.
So thank you very much, Dr. Advani, for highlighting definitely the dyslipidemia, and more so particularly the younger population of India, and the impact of the dyslipidemia in the atherosclerotic disease production, which definitely is a very, very bad disease for the society. So now many things have been already clarified, but there's one of our friend, Dr. Neeraj Prasad, is also available with us, and I would like to definitely welcome Dr. Neeraj Prasad for this particular important meeting. Dr. Neeraj Prasad, can you hear us?
No, I'm not able to hear you, and the face is not seen here. I have
Face
it has
is all right.
the mobile contact has jeopardized. It has gone down, so it's not coming up.
Okay, fine. Can you give your comments on this, whether younger individual gets a different type of the complication in the if they have dyslipidemia as compared to the elderly population? Younger populations complications are different than the elderly population. Is there any way to think about it or talk about it?
Yes, no, that's true. The young population, whichever gets high cholesterol level, high LDL level, or triglyceride level, so they get symptoms, but not very, very much, just like the old people. Because of to fight against the adversities, the power is more in younger people compared to the older people.
Yes.
That's there. So it's
but
it should not be overdone. Like we should not take mutton TDS for 7 days. Then it will create problem. This is one of the major issues which have been told.
So in younger individual, definitely many of the coronary events are thrombotic event due to certain plaque rupture. While in the elderly
Absolutely.
people, yeah, in elderly population, this is basically chronic disease going on. They develop collaterals and many things, and their presentation is a different one. Now,
Absolutely.
important problem comes when a young patient come, not patient, young people
Mm.
come. Yeah, I got my lipid studies done and is
Yes.
around 230 and he gets disturbed because of he is seeing LDL cholesterol 130. Now the
Mm.
patient is asymptomatic without any family risk factor or any other risk factor. He comes and talked about the statin therapy, whether I should be on statin therapy or not. So, Dr. Advani, would you like to tell with every patient who is asymptomatic dyslipidemia by himself, but for our definition, LDL should be more than 170 to start a statin. So how do you think you will start statin at the level of 130 or 140? Because young population are coming to us with the reports without even asking, they are getting report done by themselves.
Yeah. That's why I quoted sir in my talk. So the guy who had an event and he ignored that 132 level and then ignore that thing that he has a high body mass index. He has a skewed up waist hip ratio. And in Florida, we're still admitted. And as you said, there are thrombotic of it. It's a huge plaque share in a very sub-normal. So angio was normal 3 months back. And I think that a stent not going to help it. The guy is admitted and is stented. And it's not responding because what is required is a support of the LV. The ejection fraction plummeted directly to 35%. It's chemically non-preconditioned. So these guys who see that the reference range is and that they see that 130 is okay. I think 130 is very high, sir, in India. Even to somebody who's 24, 25, because there are other borderline CVRFs and constellation of cardiovascular which he is not aware of. And they constellate and aggressively insult endothelium, which he is not aware of. So, and if he has a family history of premature heart disease or say heart disease, and his cholesterol is 130 and one more risk factor, then I'd go for a modifier if you want an objective. If you go for a CAC score or a CDA, and you'll find there just something that's already sitting. Or if you do an ABI or the popliteal artery scan, there's a plaque already sitting. The IMT is already high. So 130, picture perfect 130 with no other risk factor is rarity in India. So these guys actually should aim for LDL less than 100 or say 70, in spite of no reported prior event, ACS or a cerebrovascular event or any other documented CAD stress KG is not positive yet. But then I think these guys are still high risk of, not extremely high risk, but high risk of ASCVD. So have to be on at least low to moderate dose of statin rather moderate to high dose of statin. This is my take.
Okay, what
The
do you think
commonest
about
cause, the
sun
commonest
tracking?
cause of young heart attack patients is this abnormality only, that the cholesterol rises, and the youngest person with MI which I have seen is 8-year-old. Even
8 years.
6-year-old person, yes, 6-year-old person has come with MI. This was in the initial period when the awareness was not much, but now I had spread the awareness in my local place. So it has come down drastically. But what I have seen is that young persons, even if they take irrespective of any stopping, and they go ahead with all mutton and all the things, and then they land up in trouble.
Yeah,
So
so young MI are definitely more common with homozygous hypercholesterolemia. And your patient who was around 8 years old, I don't know whether he had that homozygous type of dyslipidemia or not, but there may be many other
He had
factors in the young. Yeah,
he
he
had
had.
gross dyslipidemia. He had gross.
Yeah. So it's very difficult to treat homozygous hypercholesterolemia because we have a very limited drug which are working. The one drug which was initially told was mipomycin. Mipomycin isn't available in our country, but then we got some PCKS9 inhibitor. They got approval for homozygous, and inclisiran is not working in homozygous. This is
yeah.
very clear because we talk about many new drugs, but inclisiran is in Orient 5 trial has been shown not to be effective in homozygous. So we have got limitation, even statin are not effective. So this patient ultimately go for either lipid apheresis,
FTSS,
LDL apheresis, or genetic treatment or liver transplant. This is the way we treat homozygous. I have got in all in my total life practice from 2002 till now. is a 7 patient, and one of the slide I had shown, that was a homozygous patient, because his total cholesterol was around 800 and LDL was 712. And he was one of the very rare one, and the one also similar like that. One simple question: if a young student comes to us, say my cholesterol has gone up, so I tell them, you just do lifestyle program. They will talk to me. Okay, we read about the statin. Then I have to tell them, okay, this cholesterol is also required for your hormone synthesis also. So if you put every young patient without risk factor statin, will it affect their hormonal synthesis? Hormonal synthesis, because that is also equally required to continue your life, because the sex hormones are mostly made of the cholesterol.
Yeah,
So
can I take that, sir?
Absolutely.
go ahead.
Go ahead, yeah. Go ahead.
Yeah, so I think the brain synthesizes its own cholesterol, right? They have their same HMG pathway there also, so they don't need it. Most of these androgen cholesterol, they are synthesized in the brain. Androgens, they synthesize their own cholesterol, so they don't. This is the liver is synthesizes for the muscles, and then it circulates, and muscles also have an alternative pathway there. So because why muscle aches happen, so we do HMG co-inhibition there also. So similar, and this is acyl co-synthesis with bempedoic acid. That's on it spares the muscle because there's pathways. So and also there's some amount of cholesterol required, minuscule amount of for hormonal synthesis is there in the other non-LDL the other lipid like VLDL, the remnants one. They're not disappearing with complete statin therapy, and they still provide the thing. So by and large, hormones, unless he is growing after 18, it is not going to affect the other quintessential body homeostatic purposes. This is my takes.
Okay, fine. So
any other departure with you, sir, for any other opinion?
no. It's something like we have to explain the patient and see whether he is a risk factor or is developing risk factor-like phenomena. Then we definitely ask him to be on a drugs like statin and with dietary precaution, lifestyle modification. But those who are very young and coming again and again with the report, then I tell them don't bother too much because you're asymptomatic. Unless you've got very high oxidative stress, then there's a chances of more LDL oxidation. You are likely to develop early atherosclerosis, something like that. I talk to them because early atherosclerosis can say when more oxidative stress with more LDL oxidized LDL. This is what. So now very important duration and exposure and the level of the LDL, which is very important. So in the younger individual, when the duration of the LDL exposure is very high, because they start getting dyslipidemia at younger age, say the age of 35 or 30. And so today we always talk about the higher exposure of statin for longer time, higher dose and for longer time. So your strategy for moderate and high intensity is very well accepted, particularly in the patients who are having high risk. So Dr. Neeraj, would you like to continue with the high dose statin for every patient once your acute coronary syndrome has settled, your LDL level has come down to
Of
the
course, yeah.
70
We
or
could,
60?
if there is 70 plus, then if they tolerate, a lot of people know what I see, especially in my state, Jharkhand, that once you give a high dose of statin,
Yeah.
they are not also. They from 10 to 20 milligram to reduce the LDL, which give used to give IV in and lot of that's
Yeah, I don't know whether we can hear Dr. Neeraj. All of us
okay.
are hearing.
Go ahead. Okay, I think you have discussed a lot here.
Okay, fine.
Okay.
So thanks
Any
a lot.
other
Dr.
any other
Advani,
point you want to raise?
yeah, one more thing, Dr. Advani, regarding ezetimibe. Yeah, you has very clearly pointed out is the one of the additional in our armamentarium. Once the statins are not working to the extent in the higher dose, if they are tolerating 40 milligram, yet we are not achieving the goal. So ezetimibe can be started definitely in every patient. So when do you start? Early start in acute coronary syndrome, or day 1 or day 10 or day 7 or something like that?
No, no, sir. In acute coronary syndrome in a youngster, I start right away without even the blood sample has gone. I don't know the report. I started. And there's an airline paper that there's 40 mg of Rosimo or 80 mg of Atrova, Pempetoic 180, and then an ezetimibe 10 mg right at beginning. In spite of that, so you go all guns blazing right at beginning. And this is not for LDL. They specify everything there, and inflammatory and oxidative value, periparakar and penumbra. So this is for all that. And then after, as you said, that the things settle, and then one can take a call. So in acute setting, I'll give ezetimibe for sure, irrespective of LDL level. When this guy maintains for 7.5 months, 3 months, 6 months, then I have a call, because now your fixed dose combination in any ways it takes only one pill. So you can
Yeah.
still continue, and if it doesn't improve his lifestyle, I might still continue. That's way. But then LDL, I won't let him go beyond his LDL designated level forever for rest of his life.
Yeah, that's correct. Yeah, very, very important. There's one also terminology in the lipid management is the risk enhancer. Risk enhancer in dyslipidemia management, and we often don't talk much, but there are diseases like collagen vascular diseases. Patients who are on immunotherapy, they are not usually shown, but they are basically risk enhancer, and they are also candidate for high intensity medication if they develop coronary, when whether the LDL may be still within the range of 70 and 80, but they should be provided. So all those risk enhancer per class of a patient, particularly collagen vascular disorder, patient transplant, patient with the immunotherapy.
And psoriasis and preeclampsia,
Yeah.
inflammatory bowel disease.
Yeah. So they are also candidate where we don't talk much about, but that population also comes to us. So
Yeah.
when we are almost at touching at the end of the session, any role of genetic counseling, engineering, or genetic engineering in the management of dyslipidemia? Available, progress, and expectation. Role of genetic counseling.
But this is again falls back to FH and HS. And it's disheartening that I heard that you said ever since in 25 years of practice, you saw 6 or 7 homozygous.
6 only, 6.
6. I was just wondering, Vidyut sir, thanks for telling it. मेरे को लगता था कि homozygous इंडिया में होता भी है कि नहीं?
नहीं, मैं नाम से बता सकता हूँ पेशेंट को.
अच्छा, this is so.
ये 6 पेशेंट. ये लास्ट पेशेंट का नाम विजय गवली है.
अच्छा, boy, must be a boy. Yeah,
Boy,
young guy.
no? And I've seen the first patient who was at the age of 2 years, and his sister was around 7 years. That was first 2 pair patient. They were siblings, so total 6 patients. So I know all the name also because they are coming to me for 17 years, almost 17, 18 years. The last patient which I've shown the slide was Vijay Gavli. And after that, there's another patient whose name is Mr. Bhomik. He also works in a hotel. But well, it is known. But
so how do you manage, sir, now? These guys go periodic.
The management still remains challenge for me till today, because initially we didn't have an ezetimibe, but I used to give possibly maybe it will work, but it never worked. So that one of the initial patient, the girl, he became doctor also, and she underwent LDL apheresis recently. Regarding her brother, I do not know. Then there are 2 more patients. One patient is having, of course, he has developed coaptation even, not only but his mother, then I gave him that patient this PCKS inhibitor, received 6 injections, and after that they don't want to receive it anymore. This last 2 patients, Vijay Gavli and Bhomik, they were from different places. One was from Shahjahanpur and another one was from Calcutta. I tried to convince them for free treatment also. And the drug which is recommended is basically Mipomersen.
Yours available.
And I was basically principal investigator for that trial. But at that time, these patients were not in Indore. And whatever patient I had, they were below the age of 18 years. So I was not able to register them, although I had patients, but they were younger population. So FH is a very, very difficult, HOFH, sorry. And then
heterozygous does exist, but we don't see many patients. I see LDL is 192, and I how do I do a cascadic screening?
That's why I showed the original report. I didn't made up.
Yeah.
to authenticate, okay, these are the patients who are coming to me, in total 6 patients in 20 years, total 6. And very unfortunate, okay, I am helpless to them, despite mipomersen, and mipomersen is, I think, not commonly used nowadays. It was marketed as the name of Kyan Maro. Yeah. So anyway, and it was a drug from Zenzyme, which basically makes the drug for the what we can call orphan diseases, because this is something like incidence is 1 in 1 million. Well, heterozygous also, as you were telling, incidence earlier we used to tell 1 in 500, but now we have to talk something 1 in 200, as you told, okay, because it was underestimated.
So I was reading in Times of India that around 50 to 60 lakh people with familial heterozygous hypercholesterol do exist. And then this was corroborated with Dr. J.P.S. Sahni. And I find that way. I think that way. Again, and thankfully in these, I think the same drugs respond. The same, the we treat Indian dyslipidemia. So again, go with the same algorithm.
So anyway.
Yes, sir. There was a question in the chat box.
Let me see. I don't know. Let me find out. Okay.
Yeah, there are a couple of questions in the chat.
Okay, you go ahead.
Yeah, so there are a couple of questions in the chat box. First question is like, in which patient profiles do you use rosuvastatin 10 plus ezetimibe 10, rosuva 20 plus ezetimibe 10, and rosuva 40 plus ezetimibe 10?
Well, Dr. Advani should talk about it.
Yeah, well, this is a question like 10 rosuva and 10 ezetimibe, then 20 rosuva 10. Again, like we call it moderate to high dose statin or low to moderate dose statin. Yeah. Again, I say that I have a patient sitting here. I've decided his LDL target by whatever jargon, right? By using the apps or the risk mark or the factor. I've decided LDL target prior events, ASCVD, his phenotypic characteristic. I decided LDL say 40. I have to bring him to LDL 40, right? So I may or may not use ezetimibe there if he's not in ACS. I started, say, a rosuvastatin 20 mg, and this guy in 1.5 months and in 3 weeks or 1.5 months has fallen back to 38. I don't need ezetimibe there, right? Or as Dr. Vidyu sir asked me, if you have ACS and a patient coming in as a youngster, I am giving everything without knowing his lipid profile right away at the loading dose. Either Atrova 40 or 80 or Rosuva 20 or 40 with whichever ezetimibe and also bempedoic acid, because I want it to work immediately. There's no scope of any leeway. Having a permutation combination 10 and then 10, 20, 10, 20 and 10, I think it's your thing. Like if you are not tolerant, you think you have statin induced muscle symptoms and you want to have 10 mg only and then you want to increase ezetimibe, you can do that. Finally, you have to come down to that LDL designated level, which I want my patient to come to. Otherwise, I have to keep on increasing my weaponry, which I have one after another. So I don't think any rational like this indication के लिए ये है, इस indication के लिए उतना dose है. I have to use a moderate to high dose of statin to most of my high-risk patients and bring them down to. I might take the help of ezetimibe also. Or if he is having a statin-induced symptom, then it's a different story. Then I have to say that's another topic in itself. Or statin intolerant, then is another topic itself. So this question is partial in that way. Did you, sir?
Okay, fine. So, well, ezetimibe is definitely another drug in our armamentarium, and it has been shown in the certain trial it reduces a sudden cardiac death in addition to statin, not alone or monotherapy. So, well, and we have seen the reduction of LDL with addition of ezetimibe up to 25%. That is in the Emcure IT trial also, we have seen. And the reduction of the MACE by 33 to 35 to 33 if you add ezetimibe. So, well, Emcure IT trial has been accepted all over the world. Yes. And people have definitely been using the drug. Now, permutation combination should be definitely patient-to-patient judgment rather than blanket advice. You should do this, you should do this, patient-to-patient. Some patient tolerate 20 milligram rosuvastatin. He doesn't tolerate anymore, then you will use ezetimibe there and then at that level also. So that is one part. So Dr. Neeraj Prasad, yeah.
So last question is, what will be your advice to young Indians to live life free of lipid abnormalities?
Leave India. It's very difficult. So I think It's all genetics. Many of the things are not in our hand, including me or probably with you, sir. Anybody is not. We all are Indians. We share the same genotype, irrespective of caste, creed, religion. And also, what is not declared and as a risk factor is adulteration in the food and environmental inorganic pollutants. And they also incite the endothelium in an inflammatory way, and then there's a higher reactive oxygen species. Because of that we inhale, we don't count them as a risk factor, and they disturb the already deranged homeostasis. So living free of dyslipidemia mean, of course, heart healthy lifestyle, if the mentality, the sleep, the diet and exercise and muscle and fat, okay. But if you're genetically doomed, there could be some still leftover residual lipid abnormality which mandate managements. So heart healthy lifestyle is the only answer. And living pollution free is another thing. With you, sir?
Well, we cannot change our genetics, but we definitely should adopt a healthy lifestyle, which I think you already highlighted, and try to reduce the environmental risk factor as much as possible. And definitely check your lipid profiles. And in case you need apart from the lifestyle, you need medication, you may be on medication. And this medication, when you are supposed to give for a longer time, one should be careful for observing the side effect. And always look for the newer options which are available with less side effect. Newer drugs are always on the card. And since, we should always think about a statin, but beyond statin also, the new drug will come. We have learned about bempedoic acid, glycerin, and other drugs. But anyway, case to case will be variable. But younger individual, if they develop dyslipidemia, it's definitely not good, because one of the family husband wife had come and I started talking about the lifestyle modification. She asked me, बोले साहब नहीं खाएंगे तो कब खाएंगे? तो वो मेरे पास कोई जवाब भी नहीं था. She was 27 years and her husband was 32 years. बोले साहब अभी नहीं खाएंगे पिएंगे तो कब खाएंगे? तो ये कई बार it's very difficult in your clinical practice. Think yourself in that position, then you realize, well,
you
we should
use
try as much as
inclisiran?
possible, and we should take the help from the nature also, and we should try to provide.
Sir, you've used inclisiran as of now?
Sorry, I can't listen. Dr. Ashish, Rishi?
Dr. Prashant sir is asking a question like
Hello?
whether you use
Yes, sir.
inclisiran.
You are dropping
Yeah.
out on a connection. Vidhu sir, you have used inclisiran?
Dr. Rishikesh?
So there is one question
Quick
from Dr. Prashant sir, like he is asking whether you use inclisiran.
I can't listen now.
Yeah, he's not able to listen.
Okay.
Dr. Rishikesh, no ways. This is what journal. This is
I
out of
use.
view of the
Okay.
talk. Absolutely. So Rishikesh,
Sir, can you hear us, Dr. Vidyut Jain sir? No,
I
I
think
think it's
neither
connection
Dr.
loss.
Neeraj is also not probably able to hear.
There's a lot of disturbance here.
Yeah, G.
Lot of
Well,
disturbance
I am not able
because of the heavy rain. Because of the heavy rain.
Well, it's
It's
good
little
to hear
disturbed.
that there are heavy rains. I asked Dr. Vidya, did you use inclisiran or Dr. Neeraj?
I heard little bit,
Dr.
not
Rishikesh,
much.
I am not able.
So genetic thing, one thing which I wanted to contribute was that I have the experience of working in South. I was in Jipmer for 10 years. Then I worked in Lucknow and then in PGI Chandigarh. And then lastly, I came to Jharkhand. So I
So
found
both in India.
different, so I found very different approach and very different susceptibility of this. What I found was that in South India, the Malayalis were very much prone, and Kannada. These things were very much. Tamilians were not that high. They were high, but they were not high, that much high. And there is very diffuse and very measured lipid profile. This I have seen there. And this we should tackle. I was in Chandigarh, there also I saw in Punjabis, they have very, very high protein and the cholesterol. And there we had faced a lot. But in East India, it's very simple. and very good. This is my experience in all the three places. Okay.
Dr. Vidyut Jain, sir, can you hear us?
Dr. Rishikesh, as soon as you
I'm
suddenly
not able
appear,
to. I don't know whether you can hear me or not.
Yes, sir.
But-
Yes, sir. We can hear you.
you can't hear.
Hello, if I'm audible, fine. So we had a wonderful time today to discuss some of the aspect of the dyslipidemia, right from the history of dyslipidemia, then the development of the understanding of atherosclerotic event in the coronary artery tree, presenting sometimes with acute coronary syndrome, which is a very bad disease. So this is one of the non-communicable diseases. Still, that we are not able to bring down this incidence as much as we need in our society. One of the armamentarium in management of this particularly dyslipidemic patient may be drugs like statin, but to use it properly in a younger population is very, very important. In a higher dose should not bother us, but we should be vigilant. And number two, addition of other drugs like ezetimibe, or at one time or other time patient requires bempedoic acid, or maybe he requires PCSK9 inhibitor, that may be out of compulsion because patient is not responding and patient has got polyvascular disease with multiple event. So all this is the story definitely moves around the dyslipidemia management to prevent the sudden cardiac death and mass and the recurrence of the disease. This, I think, our fight should continue, and we look for the newer option in future. And as one part which has been discussed, if we are genetically different. We are genetically different, but we have to think more about the genetical treatment in future. Maybe not now, but after 10, 15 years, there will be multiple options for that treatment also. So thank you very much, Dr. Prashant, Dr. Neeraj, and Dr. Shevle for organizing this meeting. Thank you once again.
Thank you.
We are
Bye,
nearly
Dr.
at the
Rishikesh.
finish line. But before
Right.
we conclude, let's express our gratitude to all those who made this program possible. I extend my deepest gratitude to our distinguished speaker, Dr. Prashant Advani sir, for his insightful presentation. Your deliberation has undoubtedly expanded our understanding pertaining to managing abnormal lipids in young Indians. I would like to express my sincere gratitude to our esteemed moderator, Dr. Vidyut Jain sir, and expert panelist, Dr. Neeraj Prasad sir, for sharing their research, knowledge, and expertise with us today. I would also like to thank our esteemed audience for their active engagement and for making this program a resounding success. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Let's carry this knowledge into our practices, research, and advocacy, fostering a healthier future for young Indians with abnormal lipids. Thank you once again for attending and encouraging us. Good night and good time. Thank you.
Good
Thanks
night.
a lot.
Bye,
Thank
everybody.
you.
Bye, Dr. Rishikesh.
Thank you. Thank you,
You
sir.
look
Bye,
like
sir.
Arnab
Thank you, sir.
Goswami.
Bye bye.